Let us discuss about the temporomandibular joint and the muscles of mastication. Temporomandibular joint, it is a condylar joint, which is a type of synovial joint. Remember, it is also called as bicondylar joint because both the joint condyles are involved in the movement. This is an articular tubercle. Remember, this is an articular tubercle which is present anteriorly. It is the only minimal support which is present anteriorly. Hence, the anterior dislocation is more common. One more thing, remember this: the capsule of the joint capsule extends from the articular tubercle to the neck of the mandible, and from the neck of the mandible it goes to the mandibular fossa. This is called as capsular attachment. This is a capsular attachment, joint capsule, and this is the articular disc. Articular disc is an extension, which is also called as fibrocartilage, is an extension from the lateral pterygoid muscle. Lateral pterygoid. This is the lateral pterygoid muscle. From the lateral pterygoid, extension of the lateral pterygoid muscle, attached peripherally to the joint capsule. So remember, it is attached peripherally to the joint capsule. Now remember one more thing is this is a tympanic cavity. This is the tympanic cavity, and this is the temporomandibular joint. The space between this is filled with adipose tissue, which helps in the movement of the condylar joint of the mandible. So this is the upper joint space. This is the upper joint space. This is the upper joint space, and this is the lower joint space. This is the lower joint space. Upper is what? Loose and laxative. LL and TT. Loose and laxative. Lower joint space is tense and thick. So this is called as upper joint cavity, which helps in the sliding and gliding movement, while lower joint cavity helps in the rotatory movement. Lower joint space is the rotatory movement. Upper joint space is for what? Sliding and gliding movements. So that is what I have written here. That is, the anterior dislocation is more common because of the anterior articular tubercle eminence, which provide the only minimal support. Because this is the only minimal support which is present. Excessive opening of mouth can also lead to the anterior dislocation. Now coming to the next point, gap between the tympanic plate posteriorly and the temporomandibular joint is filled with what? Adipose tissue, which allows the smooth movement of the condyle, which allows the smooth movement of mandibular condyle. Now coming to the disc. Disc is attached peripherally to the joint capsule and it is an extension of lateral pterygoid muscle. It is an extension of lateral pterygoid as well, and it is peripherally attached to the joint capsule. Now coming to the capsular attachment of the temporomandibular joint. The articular from the capsular attachment is from the articular tubercle to the neck of the mandible. And from posteriorly it extends till the mandibular fossa. Now coming to the explanation, remember this is an articular disc. This is an articular disc. It is an extension of lateral pterygoid muscle. It is attached peripherally to what? It is attached to the joint capsule. This joint capsule, remember, arises from the articular disc to the neck of the mandible, and posteriorly it extends till the mandibular fossa. This is an articular disc. This is an articular tubercle, which is our eminence. It is an only pony support which is present anteriorly. Hence, anterior dislocation is more common. This space is divided into. This is a capsular space. This is divided into upper joint space, and lower joint space. Upper joint space is what? It is loose and laxative. Lower joint space is thick and tense. It is tense and thick. Remember this. Okay, now coming to the next part is the support of the mandible. There are two supports. One is the true support, which comes from the capsule. Remember the same thing. Upper is LL, lower is TT. That is loose and laxative. Upper is loose and laxative, lower is tense and thick. Now coming to the lateral pterygoid, lateral temporomandibular ligament. Lateral temporomandibular ligament extends from the articular tubercle. It extends from the articular tubercle, goes downwards and the backwards wind around the mandible. It goes downwards and backward and winds around the mandible. It winds around what? It winds around mandible. It prevents a hyper retraction. It prevents a hyper retraction, sudden going backward. It prevents the hyper retraction and holds the mandible. Fall support. Remember the fall support are two. That is the stylomandibular ligament and the sphenomandibular ligament. Stylomandibular and the sphenomandibular. Remember from the spinomandibular ligament arises from the spine of the sphenoid to the mandible. That is the lingula of the mandible. This is called a stylomandibular ligament. This is called a spinomandibular, from the spine to the mandible. Between the spinomandibular ligament and the neck of the mandible, there is a vessel which is present, which is called as maxillary artery between the neck of the mandible and the spinomandibular ligament. This is called as spinomandibular ligament. Now coming to the stylomandibular ligament, between the styloid process, the styloid process and the mandible is called as stylomandibular ligament. So two ligaments, stylomandibular, spinomandibular. Now coming to the neurovascular supply of the temporomandibular joint. Neurovascular supply, remember the blood supply for the temporomandibular joint comes from the maxillary, two terminal branches of the external carotid, that is the maxillary and the superficial temporal artery, while as the nerve supply comes from the auricular temporal nerve and the branch of the mesenteric nerve and the temporomandibular auriculotemporal nerve. Remember there are two types. There are muscles of mastication are not arise from the medial pterygoid. Medial pterygoid of the sphenoid bone does not give attachment to the muscles of mastication. Instead, they give support to the pharynx. For example, by giving the attachment to what? Origin of the tensor villi palatini happens from the medial pterygoid. plate, and also the lateral pterygoid plate. For example, key attachment for the site of muscles of mastication. Lateral pterygoid plate is the key attachment site. So remember, the lateral pterygoid has two surfaces, medial surface and the lateral surface. Medial surface gives us the origin of medial pterygoid. Lateral surface gives origin to the lateral pterygoid muscle. Thus, the lateral pterygoid plate directly contribute to the muscles of these muscles. That is the muscles of mastication. So remember, lateral pterygoid fibers are backwards. Remember, the muscles of lateral pterygoid fibers are backwards. So it is responsible for from L, that is the lower the mandible, from P, that is the protrusion of the mandible, that is the lowering and protrusion. And now coming to the fibers of the temporalis go forward, it goes downwards and forward, this goes downwards and forwards. And remember, from E is the elevation, it helps in the elevation, and R is the retraction. So this is the largest muscle of mastication, this is the largest muscle of mastication, so it helps in elevation and retraction. From M is the masseter. Remember, masseter is the strongest muscle of mastication, and it is present outside. We can say from the lateral side, that is the outside. It is present outside, outside. So it helps in the downwards, the fibers are downwards and backwards. So it helps in the elevation and protraction. So all the muscles are helping in protraction, except the temporalis helps in retraction. All the muscles helps in elevation, except the lateral pterygoid, which helps in protraction, which helps in depression, that is the lowering the mandible. Now coming to the medial pterygoid, elevation, from M mediation, and P is the protraction, helps in protraction. This is also downwards and backwards. Remember, this is the temporalis muscle, this is a masseter muscle, masseteric muscle, this is the lateral pterygoid. And remember, to see the medial pterygoid, we have to cut the ramus of the mandible, as seen in the image. Cutting the, and it gives it originates from the medial side of the lateral pterygoid plate and attached to the angle of mandible. So it is arising from the medial side of the lateral pterygoid plate. Now coming to the depression of the mandible, that is the opening of the mandible, is caused by lateral pterygoid muscle if it is against resistance. If there is a resistance to opening, if we give resistance, then other muscles will assist, that is the mylohyoid, anterior belly of digastric muscle, and genohyoid muscle. These are the mylohyoid, anterior belly of digastric, and genohyoid muscle. Retraction of the mandible is with the help of retraction is temporalis muscle. Sideways movement is the alternative action, that is the medial and the lateral pterygoid helps in the sideways movement. Protraction is mainly from the lateral pterygoid muscle assisted by the masseter and the medial pterygoid. It is assisted